Hi, this is Dr. Kevin Windisch from Sparks Pediatric and Adolescent Medicine. Welcome to our video series for professionals. Sorry about the tremendous delay between videos. We've been having some software issues, but I think we've got that worked out. If we can be of assistance for you, we'd love to have you here in our office for a rotation. Give us a call at 775-359-7111. If you're a parent watching this video, we hope you enjoy it and learn something. But please remember that these videos are not intended to replace visits to your regular physician. If you would like your baby seen, we'll be happy to see you same day at area code 775-359-7111. We cannot help you over the internet, via email or telephone. My contact information is down here for everybody. Let's go ahead and move forward. So we want to talk about feeding issues and things, and realize that with this discussion we're really sticking to mostly term infants unless I say otherwise. Oops. Well. Alright, so the first question that comes up is how much food does a term newborn need? Because, you want to make sure they're getting enough, but how much is enough? How much is too much? How much is not enough? Well, we can make a few guesses. Term newborns need roughly between 100 and 110 calories per kilogram per day. Using homogenized breast milk or typical formula, this translates into roughly 180 milliliters per kilogram per day. And so we can make some calculations. Now, it's true breast milk is not all 20 calories per ounce. That's what formula generally comes as, though there's some Premie formulas on the market, and there's a new formula or reformulated older formula that's now 19 calories an ounce. But breast milk varies widely throughout a feeding. And we'll talk a little bit about how it changes throughout a feeding, and it can vary from woman to woman in terms of calories as well. But it's still a nice rough estimate, and it'll give us an idea as to whether a child's getting enough or not. Preemies need more, kids who are in congestive heart failure need more, children with cystic fibrosis need more. Many children with chronic disease, as long as it's not leaving them quadriplegic, will need more calories. Kids who are quadriplegic, not moving, not walking, have severe neuromuscular impairment, will need substantially less. Children on a ventilator will need less. Oh, there we go. So how often do they need to feed? Well, every 2 to 3 hours at first, and then they can consolidate after a couple of weeks. And most parents are pretty excited to consolidate down that nighttime feeding, and I can't say that I blame them. But in the beginning, it's every 2 to 3 hours. With the preemie babies, that needs to continue until they're roughly 2 to 4 weeks post-term, so 42 weeks gestation. Excuse me. Most babies wake up in time to feed, but there are a handful of babies who are sleepier than others. For those babies, you need to wake them up to feed them. And this translates into roughly half an ounce to 3/4 of an ounce per kilogram per feeding. Now, we're talking about mature infants that have already left the hospital. In the first 1 to 3 days of life, especially the first 1 or 2 days of life, most babies are taking only half an ounce per feeding, period, and that's again assuming their term. They're not taking a whole heck of a lot in the first day or two. But if you're feeding them from the breast, they're getting mostly colostrum during this time, and that's all that they need. Babies during this time are also fluid overloaded, so again, they don't need a ton of fluid. They're physiologically designed for the lower volumes. For the mature neonate, that translates into roughly 15 minutes per feeding per side if they're on the breast. After 15 minutes, babies have taken roughly 95% of the milk that's within the breast. The remaining is not so easy to get. So the babies don't get a whole lot, assuming they're feeding vigorously, are not getting a whole lot more by feeding for 45 minutes than they would if they were feeding for 15 minutes. Now, why breast milk? Obviously, there's a lot of reasons, and some of this has been well delineated in the literature. We want to stick to things for this discussion that are biochemically proven, and I want to stay away from anything soft and fuzzy. That's not to downplay the soft and fuzzy, that's simply that I don't want to take the time to discuss that. So there are some significant immune benefits. IgA passes through the breast milk in large quantities, and of everything, that's probably hands down the single biggest benefit. IgA is your secretory immune globulin. That is the one that is responsible for binding up various antigens in the gut and preventing them from crossing into the bloodstream and creating problems for you. Back in the old days, this was what we wanted to induce with polio vaccine, for example. And to that end, newborns will get their moms, assuming the moms had gotten the old oral polio vaccine, the newborns will get their mom's anti-polio IgA this way, as well as mom's anti-rotavirus IgA and anti-norovirus IgA, etc. You do get some IgG, that's your circulating immune globulin, through the breast milk, but that doesn't seem to have as much benefit because it looks as if most of that's probably digested in the gut. You get neutrophils through breast milk, and remember, neutrophils are nonspecific. They don't really care who you are. They work just fine doing their thing, whether they're inside the body of the person who made them or inside the body of their newborn. Now, they are destroyed in the stomach, but during their time alive in the stomach, those neutrophils will destroy bacteria. Lactoferrin, which helps to prevent bacterial binding, and lysozyme, which destroys bacteria, as well as complement. This is not complement as in, hey, you did a good job. This is complement as CH25. And specifically, you get C3, C4, C5, the active complement complex materials. And remember that this has antibacterial effects. And realize complement is the most primitive part of our immune system, except for skin. But with regards to things that are secreted to kill off things that are trying to kill us, within the immune system, that would be complement being the most primitive part. Primitive not in a bad way, primitive as in the single most essential part. And so, this goes way back on the evolutionary tree to help keep us alive, and so having it in the gut, and the only way to get it in the gut is from breast milk, during the neonatal period is important. Complement is not stable in lipophilized materials, so I can't find a way, or have not yet found a way, to put it into formula. So it's going to be breast milk or nothing if you want complement, and you do. Nutritional benefits. Well, breast milk changes over the course of the feeding and with time. Start with time. In the beginning, it's very, very, very protein rich. In fact, it's almost pure protein coming out. That's colostrum. And then later, as the milk matures, fat starts to go into the breast milk. That's important because the newborns don't need the fat, they do need the protein. Over the course of the feeding, it changes as well. Breast milk is protein rich and fluid rich in the beginning and fat rich at the end of the feeding. What is the advantage to this? Well, the advantage is that the majority of the volume that you feed doesn't need to spend a lot of time in the stomach and can pass rapidly into the intestines, decreasing the intrastomach volume. The hind milk, which has all the fat, does need to spend time digesting in the stomach. However, it's going to be low in volume because you've already dumped most of the volume into the intestine. That means the stomach's not distended, And if there's less in the stomach, then there's less to reflux, spit up, and throw up. That hind milk can stay in the stomach, it can be digested until it is passed, and by staying in the stomach, it provides you with satiety during that time. So there's a lot of advantages to this. The iron that's in breast milk is also almost 100% bioavailable. Nobody's ever been able to give me an explanation that made sense as to why that was. But we do know that it's almost 100% bioavailable. Breast milk is lower in iron than formula in terms of milligrams of elemental iron per milliliter. However, with its high bioavailability, we actually see less iron deficiency anemia in breastfed babies than in formula-fed babies. Because there's lower iron in the breast milk than in formula, we see less constipation in the babies who are breast milk fed. What are the implications of all of these? Well, you have less infection, less allergy, less asthma, less reflux, and less iron deficiency. Contraindications in this country to breastfeeding. An emphasis on in this country. Maternal HIV, maternal hepatitis C, and maternal hepatitis B. That last one's highly questionable. The hep C, if the hep C titers are low, you can still technically breastfeed, and there is research as to thresholds beyond which or below which you don't need to worry too much about hepatitis C. But I would argue if mom has a strain of hepatitis C that she's not able to clear, considering it has a 1 out of 3 chance of killing her, do you really want to run the risk that that's going to be transmitted to a baby when we do have the availability of something that'll keep you alive and not transmit a fatal disease to you? Hepatitis B is a little more controversial because the babies can be vaccinated and they're going to receive HBIG, hepatitis B immune globulin at birth. So if they got the immune globulin and then they're vaccinated so they have immunity, do you really need to withhold the breast milk? It's a discussion you need to have with the parents, and informed consent provided. Moms who are IV drug abusing really should not be breastfeeding, although the majority of those moms aren't going to go through the work of breastfeeding. People who are receiving radiotracers like I-125, people on chemotherapeutics, people with hyperthyroidism, not hypothyroidism, who are on PTU, propionate-uracil. We don't need to worry about tapazole, however. More importantly, because much more common, is hypothyroidism. Moms on Synthroid absolutely can breastfeed. In fact, being hypothyroid and unregulated will make it very difficult to establish breast milk supplies. Flagyl use in the mother is a contraindication. Galactosemia in the infant, because these children cannot break down galactose, which is found in both cow's milk and mom's milk. More importantly, because I've seen this happen way too many times, it is okay to breastfeed after mom has received general anesthesia and or IV contrast for CT, MRI, or other radiologic procedure. Cannot tell you how many moms I've seen who've had to go in for a CT scan or had to have their gallbladder out and were told by anesthesia or radiology to pump and dump their breast milk for a few days postpartum. That's crazy. No, you absolutely can breastfeed. You absolutely should breastfeed. End of discussion. Now, formula comes in various flavors. We're going to discuss them. Cow's milk formula is kind of, and yes, we want to emphasize the importance of breast milk, and please don't send me emails talking about how evil cow's milk is, or cow's milk formula is, but we do want to talk about it because there's time and place where we either have to use it or need to use it, or the moms want to use it, or mom is dead. So we're going to have that discussion now. The default formula is cow's milk based. So the protein is whey or whey and casein, depending on which flavor you're using. The fat comes from safflower oil, coconut oil, and sometimes palm olein oil. Palmolain can bind to calcium and form an indigestible soap in the gut. This is hardly the end of the world. However, to get the calcium in, then you need to increase the amount of calcium in the formula, so there's a lot of biochemistry that goes into making this. The sugar is lactose, cow's milk sugar, or milk sugar. That is an issue if you are lactase deficient, which most babies are not, although they can become temporarily lactase deficient. Lifelong lactase deficiency generally is not seen in the neonatal period, but it's a huge deal for patients with hereditary galactosemia. The next is soy-based formula. The protein is soy protein. The fat is soy oil and coconut oil. Occasionally there's palmolain oil and hydrogenated safflower oil. The carbohydrate is glucose or sucrose. In other words, it is galactose-free. It's also lactose-free, so for patients who can't tolerate lactose, like temporary lactase deficiency after a bout of bad diarrheal illness, soy formula, at least temporarily, is a good choice. For patients with galactosemia, it is the only choice. And then come the protein hydrolysates. There are several on the market. We want to stick to the ones that are over the counter. We're not going to discuss the prescription-only ones. But there's plenty of role for the prescription-only ones too, but that's outside of the scope of this discussion. The protein is casein hydrolysate plus L-cysteine, L-tyrosine, and L-tryptophan. The fat is safflower oil, which is an MCT oil, soy oil, and occasionally some palmolain oil. Carbohydrate is glucose and sucrose. In these hydrolysate formulas, protein is broken down into 3 to 5 amino acid chains, and as such, it's hypoallergenic. You can still react to it. I've seen it happen, but you don't see it all that often. So for patients with severe unmitigated allergies, this is a formula feeding of choice. More importantly, for patients with cow's milk protein intolerance or cow's milk colitis in the gut, we wind up needing to use this because the kids become cross-sensitized to soy formula, at least initially. So we start with this. The allergy, the colitis will settle down. And it's not a true allergy, it's a T-cell mediated response, but the immune reaction will settle down. The gut lining heals itself, and then we can change the children over to the better tasting, better smelling, and much cheaper soy formula. At a year of age, we can introduce cow's milk to most of these kids, and they do just fine. So we've already kind of gone through the uses of each formula. A little bit about preemies for you. They have some special needs. So they're deficient in iron, deficient in protein, deficient in calcium, and these deficiencies may not be measurable. Remember that your third trimester is when you pick up your stores of each of these things, and so if you shorten that third trimester, you don't get the stores. So we need to replace all of these things in their diet. The iron we will replace with multivitamin with iron. The protein is higher in Premie formulas, or we'll add a little bit of formula to breast milk, or we'll feed the kids breast milk and give them 1 or 2 feedings of Premie formula a day to get the extra protein. Same thing with the calcium. It's higher in the Premie formula, or you can feed them cow's milk formula once or twice a day on top of their breast milk, or you can add a little bit of powder into the breast milk and enrich it. Multiple ways to accomplish this. The formulas range between 22 and 24 calories an ounce, and we talked about there being extra calcium and protein in there. Alright, so what are the resources for you? Well, certainly this video, you already know where it's posted because you found it on YouTube at our YouTube site. Harriet Lane Handbook has good information on this. The American of Pediatrics Pediatric Nutrition Handbook has tons of information on this. So, We hope that this has been of value to you and furthered your education, your understanding of feedings of infants. And we hope that if you'd like to come visit, that we can be of assistance here in our office, or if you need to make an appointment for your infant, give us a call at 775-359-7111.